Yeah, good morning. Stephan Schug is my name. I'm from the University of Western Australia in Perth, and it's my pleasure to welcome you to this next session, which is extremely interesting because we have now one session on the efficacy of analgesics, and we have now one session on the efficacy of non-analgesics, talking about placebo and nocebo. And as Dan has already said, we have, for logical reasons, decided that we start with the good thing, the placebo, and then finish with the bad thing, the nocebo, because we felt that it's a better order to present this fact. It is my absolute pleasure to introduce to you Professor MaryKorula. I guess many of you know her because she has been a faithful member of the SIG from the, I think nearly from the start. And she has been as many of the previous SIG meetings, and many of you know her from her presentations and know her from her work she has done in India to promote and improve the management of acute pain. And Mary will actually talk about placebo, or much nicer formulated about how positive expectations are actually influencing the experience of pain. So Mary, thank you very much for traveling here and for presenting this.
I'm still a little jet lagged, so you'll have to wake me up in between. First, let me take this opportunity to thank Dan and the organizers for having me over here. I just asked Dan, can we have this session on placebo? I was supposed to talk on something else. And he readily agreed. Thank you, Dan. As usual, he's always been so supportive, and he's one of the reasons I'm still in acute pain. Okay, now Luana is actually the expert. I'm just an ordinary person, I haven't done any trials or anything, but I just want to spread the awareness of this particular effect, and that's got me interested, and I think Luana should have been the one doing that, the actual basic mechanisms and things like that, but I'm sure it'll be better if she does it later so she can sort of, contribute to whatever I've left. Anyway, coming to the topic, lately in pain medicine, there's been a lot of interest in placebo effects. And this is mainly because there's so many circumstances or incidents where placebos have shown that they do work where other modalities don't work. And also, experts and researchers all over the world are now advocating this. Every issue of this year's pain journal had at least one trial, placebo or nocebo trial, and Luana is the expert on this. Typically, placebo trials or clinical trials are done to actually highlight the effects of the active drugs or their doses compared to the placebos. But so many times we have seen that even the control groups show 50 to 80% of the side effect, positive effects. So why does this happen? We all wonder. Besides, I'm sure all of you have experienced some placebo effects in your clinical practice. I'm sure you have. I've had once I started my pain work, that got me interested. I do believe in miracles. I'm sure a lot of you do. But when it comes to the mental cure, I was always skeptical, When people told me that, they get cured. Even last week, one of my relatives came to me and said, I was supposed to have a catheter surgery and a knee surgery. But thanks to a strong prayer group and prayers, I don't need both. Another of my cousins who passed away recently, she had a CA cast on her breast, and she had meds all over. But she told me she was so strong to the last. She said it was her prayer group and her prayers. She never complained, ever. I always wondered why, how does it happen? I was very skeptical. But thank God now there seems to be some scientific basis, behind all this. Okay. Now, those of you who read the Reader's Digest must have seen his article last year, The Healing Power of Nothing by Jerome. And what he says is the placebo effect is the ability of the mind to persuade your body that even a chalk, stick, or water can make you feel better. Yeah, if it makes people better, it is free and harmless, why not use it? It's true. In the early 19th century, placebos were, actually adaptive medicine, which were used mainly to please the patient than to provide any benefit. But by the 20th century, it became a necessary deception. Many people thought it could be a necessary deception. And then the 1960s saw control studies. It became the norm. So naturally the placebos came up. But it was Henry Beecher's The Powerful Placebo in 1955 which brought this effect to the public knowledge. I'm sure you've read about this, no? It caused a lot of criticism. There were a lot of systematic reviews criticizing an article. And there was the Cochrane review came in 2010. But it was Archie Cochrane who said, if it can be used in the current situations, it should be encouraged. So, it's just a matter of perception again. I was very skeptical, but now I'm sort of trying. I have to believe in, because mechanisms have shown that it does work. Now, there have never been any formal definitions for placebos. It's supposed to come from the Latin word placebo, Latin translation of the Bible, they say. It's generally controlled treatments, similar in appearance to the standard treatment. We know that. And the effect is the medical intervention which improves the given outcome. It's like pain. The placebo response is the most interesting and what we are actually looking at. Reduction in the system related to the patient's perception of the placebo intervention. And it is very interesting because there is actually neurological or neurobiological, it's an active neurobiological process. And it's thought to be determined by the placebo effect, the response psychological factors like benefits, expectation of benefits, classical conditioning, verbal suggestions, social observer learning, behaviors of healthcare providers. I'm sure we've all experienced it sometime in our life in medical practice, and the natural course of the disease. But the basic mechanism everyone thinks is expectation. If you can induce expectation, that can produce an effect. And the magnitude will depend on the dose of the expectation. The positive and higher expectations, naturally you get better results. But then it may be part of any active treatment that we give, isn't it? Depends on the instructions we do. So, is it still considered fake medicine? My husband calls me a fake doctor now. Yeah, and but he's a specialist in reproductive medicine, and I tell him at least 50% of his patients, infertile patients, will conceive because of his active counseling. I'm quite certain about that, and he also knows that. But he has to. We always have these contradictions. So, is it necessary deception? Can we consider it necessary deception? Now, the whole problem with these placebo trials are we haven't been able to come to we don't have any proper active trials which prove this way or that way. Because these responses are so variable and so unpredictable, isn't it? But that's again because it's our fault. See, placebo pills are usually passive. Now, active drugs have their side effects, especially if you use antidepressants and things. So is the placebo effect the same in placebo and the drug group? Now, these are the problems. So using passive placebos in trials, they've already spoken about trials, it limits the understanding of the real efficacy of the drug, and the patient knows that his chances of getting the drug is only 50% if you're in a trial. So your expectations are lower, naturally lower. And so positive expectations may be higher actually in clinical settings than actually in the drug trials. And there's so many artifacts that can come in this, like they were all mentioning. Natural healing processes, headaches, idiopathic headaches, migraines. What happens? There are ups and downs. It subsides on its own, and you give the placebo at the peak of the headache. Anyway, it comes down, so we attribute it to the placebo effect. So there are a lot of things we have to take into consideration. Statistical artifacts can affect regression to mean, the sampling. Then instructions and context when you're giving the treatment is very important, isn't it? Because in different trials, it may be different instructions. They're not the same instructors in every trial. So that can affect your trial too. And sometimes they can even, like if you're using a sham acupuncture as a placebo, they can act as a counter-active, isn't it? Then again, that's going to change your actual trial, results. So should we use active placebos for the same side effects? Again, the people dealing with trials will give us a better answer, I'm sure. Now, placebo effects have been observed not only in analgesia, immune responses, Parkinson's disease, drug abuse, and all these are the main analgesic, main areas of pain relief in post-op analgesia, mainly post-dental, post-thoracotomy, osteoarthritis, migraine. IBS is the most studied placebo analgesic effects. Even the Harvard School has started their studies in 2010. It happens even with experimental somatic pain. That is, even with experimental, you get a placebo effect. And it has been shown again and again, sustained pain with hyperalgesia. Whenever there's hyperalgesia with sustained pain, the placebo effects seem to work much better. And it's, as we know, it's more with the subjective symptoms like these rather than objective like hypertension, ischemia, and all that. Joanna is going to give the placebo effects, but then it goes side by side. Now, if the patient's perception is that drug is going to be harmful to him, that's going to produce a negative effect. So it's the same placebo effect. It's the same placebo effect according to the instructions given to the patient. Now, placebo effects also act the same way, They can occur with verbal suggestions, social observer learning. Social observer learning is one way when these, they say that observing others is one way that pain-related beliefs and attitudes are acquired, and sometimes empathy. And impact of helplessness and catastrophizing, they have a real impact, The more helpless the patient, the more they are prone to negative. They can be prone to the negative effects of the drug. And it has been shown again and again, somehow the nocebo instructions have a longer and lasting effect rather than the placebo effects. We don't know why. So again, the question is double blinding and randomization in trials of any use. There can be so many errors there. So coming to placebo analgesia, it's a subclass of, you can consider it a subclass of placebo response, and it's one of the most studied of the placebo effects. Now, it can be, a lot of us think that it can be exploited to treat pain, and this is more if the patient has the urge to have pain relief and expects to get the pain relief. Now, pain relief may be from psychological factors, but remember, now it's being proved that it's not solely so. Classical mechanisms. The mechanisms they say are classical conditioning. Now, it's a process of learning. Conditioning is a process of learning that drug cues signal pain relief. And these can cause neurobiological changes. Changes in dose expectancy and total response expectancy. And as I said, reduction in anxiety, because anxiety-related hyperalgesia is thought to respond much better with placebos. And they have shown now, without doubt, that both the endogenous opioid and the cannabinoid systems are activated during a placebo response. So multiple factors co-react to generate the placebo analgesia, which involves brain activity, connectivity, and also the neurochemistry. But again, the psychological factors are not entirely responsible, as I said. They're not solely responsible for the placebo effect. Hauser et al. Recently showed they did a fibromyalgia study as well as a painful diabetic neuropathy study. And they found that in the fibromyalgia group, 45% of the responses were due to the placebo effects. But in the painful diabetic neuropathy, they got 62% of the response. We still don't know why. And it's not associated with age, sex, race, or anything. But they seem to think that there was a correlation with this year of study, pain baseline, and the effect size. Of course, we all know industry sponsorship plays a big role in all these effects. The recent issue on pain showed that genetic disposition is a factor. I was surprised. And it has been shown again and again that pain sensitivity is inversely proportional to the regional gray matter density, especially in the ventral striatum. It's been shown again and again. What about sex? It looks like males can be fooled easier. Huh? They can be taken by verbal suggestions. But females need conditioning to get them to, though we pretend that we are more sensitive to pain than males are. But then pain experience is a combination of so many factors, so naturally it is going to be variable and it is going to be unpredictable because it depends on the environment and the situation these people are. Now, like I said, expectancy is definitely a psychological mediator of placebo analgesia. They say there's a direct chain in the affective state. And as I said, the magnitude of effect depends on the dose of expectation. It has been shown there is activation of the descending control mechanisms and the dopamine systems. And I again said effects of instruction. We all know doctor-patient and doctor-investigator relationships play a big role in all the trials. Now, I think it was Luana who showed that social behavioral learning. Yeah, she showed in her study how facial expressions can alter placebo effects. Happy faces at the time of treatment are shown to produce more placebo responses and more expectations. Like I said, there are artifacts. When you're doing a subjective, as a patient is doing a subjective reporting, what does he want to do? He wants to please the doctor also, isn't it? So he would like to, for a correct and consistent behavior, he would like to come out with what the doctor wants to hear. And of course, sometimes they come out with what they actually want to happen rather than the truth. These are things that happen. But I'm so glad there seems to be a scientific base. They're so skeptical till now. But there are so many people now, being convinced that placebo effects. Even in India, we have so many gods and so many religions in India, and we all talk about prayer and how strong prayer is and all that. But the moment I suggested to the Pain Society that, I think we should spread the awareness of this effect. Immediately, they told me to do a session last month at the South Asian Pain Congress. Next month, they've called me for the Indian College of Anesthesia conference. I'm supposed to be doing a real fake, doing the real fake doctor bit. And actually, they made me write an editorial in this issue's pain journal, Indian Pain Journal, at 2 weeks' notice. They gave me 2 weeks to do the. And yeah, I'd like to spread the awareness too, because I'm getting convinced more and more. So I would like to spread the awareness too. And there is a scientific basis now, we know. Neuroimaging and neurostudies have shown that neural mechanisms and transmitters are involved. Even the sodium, potassium, and the TRP channels seem to be activated. Event-related potentials, magnetic electroencephalography, PETs, positron emission tomography, functional MRI, laser evoke potentials, all have shown clearly that there is alteration and transmission during the placebo responses in the pain pathways. The singular frontal regions, they say the anterior cingulate is supposed to be most involved because it deals with CVS effects, anxiety, and all these. So the singular frontal regions of the naturally of the brain interact with the subcortical regions, and these are associated with pain modulation, like the descending pathways. So naturally, and it has been shown that naloxone can suppress conditioned responses. Surprising, isn't it? But not always. Okay, I'll tell you why later. The prefrontal areas and the cortical regions show dynamic changes. Polo et al. Did the study and they showed dynamic changes during placebo responses. Dopaminergic pathways are involved. It's very surprising again. When transmagnetic stimulation was used, transcranial magnetic stimulation, it can induce placebo responses. At the same time, if you apply it to the prefrontal cortex, it can actually inhibit because when the process has started, if you apply that, they can actually inhibit the pain processes, the inhibiting processes, and retain the pain. It's not only the cortex, from the cortex to the spinal cord. Changes have been noticed at the spinal cord level and all the regions of pain modulation. So different drugs, we don't know. That they say in the Quran, we know only what we know. There's so many things we don't know. Different drugs may activate different areas, producing different levels of expectation and efficacy. Now, there was a theory that placebo effects require intact descending pathways, because otherwise how does the inhibition come on? But then again, they showed in these studies with fibromyalgia and post-osteoneuropathy, they showed that placebo effects occurred despite probably through expectation, and this superseded the pain pathway deficit. So you really don't need the pain pathway, the descending inhibition mechanisms too. Placebos are, as of now, it's not very useful in chronic pain management, except low back pain, they say it's very useful, I don't know. Situational factors are more important than individual factors. But can't we use positive suggestions and expectation to increase the efficacy of the active drug? Can't we do that? Like a synergistic effect. So there is a potential for improvement, but a lot of us are still skeptical. The Declaration of Helsinki, we're all into that. First the patient and then the science. The ethical thing. I won't go into the ethics of this because that's a big topic by itself. So construction of pain is not a passive process. It's active, anticipatory, intentional, consisting of selection, organization, transformation of this knowledge and information. So placebo analgesia is a consequence of this altered construction of pain due to expectation, physiological arousal, and somatic perception. Motivation, of course, is a very important component here. But again, studies have shown again and again, personality changes does not correlate with placebo effects. I mean, you would expect it, no? You would expect, but it doesn't. And cognitive judgment seems to be more influenced in the pain processes that actually deal with or give rise to pain. That's again very surprising. And then they did a lot of trials with the sensory decision theory to see if it affects the sensory discrimination. Again, it did not, placebo effects did not affect sensory discrimination. Surprising. So it's like mainly semantic, semantic processing involving the linguistic areas. So a lot of, the patient has to hear the statements and instructions, understand their meaning, retain memory of them, develop expectation and feelings about the decreased pain. And probably the brain networks with this semantic processing interact with the emotional networks. And the emotional networks activate the pain modulation system from the cortex to the dorsal arm. And this, according to the activation, they can inhibit or facilitate placebo and nocebo effects. As I said, sensory and discriminative process remain intact, as shown to be remain intact. The early nociceptive process seems to be more modulated by placebos. But remember, brain areas have other axillary processes too. Remember that. So neural activity in the brain should be interpreted with caution, because it can be the other areas that cause stimulation and other processes that cause stimulation. So you can't just depend on the neural activity. And this, as I said, patient-doctor relationship is very important. And we know, even lately there was a trial, a placebo trial with for IBS, irritable bowel syndrome, using placebo acupuncture. And the group where the doctor talked more or was with the patient more, warmth, attention, confidence, all augmented, even in an irritable bowel syndrome, sham procedure. And of course, physical properties of the drug we know does influence, at least some of the people. Children also have shown to show more greater responses, probably because of this. And interventions like TENS, transelectrical nerve stimulation without the electrical current. Haven't you seen it in PCA, patient-controlled analgesia? I've seen it many, many times. I go for these rounds, and I give infusions. They 2 milligram per hour infusions will go. They still say, "Oh, doctor, this pain is still around." And then you give this patient control. And as for us in India, remember, these are very expensive. All patients can't afford patient control analgesia. We do at least 200, 250 surgeries per day, and we've got only about 30, 40 PCA pumps. So who will get it? Only patients who can afford to get it. So when you give that, you won't believe they'll be using 10 doses, and they say, "Oh, we are very happy. We have no pain." It's just a sense of control they have, and the expectation. It's probably the expectation that they have control over it. But I've seen it many, many times. Like even when I go for expectations, when you think of expectations, we get a lot of chemotherapy patients, cancer, especially kids. I do a lot of kids. So they come for chemoport insertions. They come there, and I like to induce them, inhalation induction, and then I put the needle. So they come there, and then they hate it. They hate having that mask, They're asleep, they're okay, but they hate it. And, but then they wake up well, they go back. When they come for removal of the chemoports, you won't believe, they have already got an IV then, so it's very easy to induce them. I just have to give something through the needle. But they tell me, if they come to me and they've seen me before, they say, "I want that mask. I want that mask." It's surprising, those people who didn't want it, those kids who didn't want it, asking for that mask, because the past experiences they had a good experience probably, which prompts them to have the same experience. So past experience do have a role to play in all this. And we know alternative medicine, homeopathy, all these, you know. I'm sure there's a placebo effect involved in all this. Miracle men, prayer groups, all this, there is a placebo effect, expectation, increasing the expectation of the patients to help. It has helped smokers quit, but it has also caused alcoholic placebos were introduced and they caused intoxication in the patient. Can you believe it? And sensory motor deficits. How does it happen? It's time, is it? Okay. Allergies. Placebos have caused allergies. And sports medicine, we know that ergogenic aids have increased performance and this has been a big controversial issue in sports medicine. How does it happen? You know? So I'm sure it's expectation again. Now, so that is why people say if you start giving the optimal, the best therapy early in the course of the disease, and if the doctor and the patient believes in that therapy, it probably is more effective than anything else. Now, coming to antagonists, as I told you, finished? Okay, sorry. Opioid, and I know I could just go on about this now. These antagonists have blocked the placebo effects, and opioids actually what their normal role is, they have a local inhibitory effect on neural transmission usually. So what actually when the opioids start working, there should be a decreased functional MRI activity. But the funny part is there's an inverse relationship between both these effects. That's the funny part. Naloxone does act, but it doesn't act all the time because the other thing can reverse. That's funny, isn't it? You know, and cues that signal decrease or produce pain, both can mediate or cause opioid-mediated analgesia. We don't know. And nociceptive conditioned pain modulation, it's like counter-irritation. Producing like counter-irritation, you produce a pain in another site of the body, away from, can decrease the perception of pain at that site. And the increases in BP, they say, can stimulate the atrial aortic baroreceptors, sinoaortic and sinoatrial baroreceptors, and those are supposed to mediate trigger the descending pain inhibition. So, as Benedict, he's done such a lot of work, Benedict, as he says, it's an integration of psychology, neuroscience, and molecular neurobiology. Finally, it all boils down to the place, the time, the route, look and feel of the treatment, isn't it? The Harvard School have already started a program for placebo studies. Of course, the American Pain Society and NIH are a little skeptical about this because this can be considered as dishonesty in patient-doctor relationship, and also it can be used for other things like to find out if the patient is malingering and all that. So it can be used for other purposes which is not ethical. So is something better than nothing? Pain has always been undertreated. Now we're using placebos to make it worse. That's a problem. It's not a proven treatment. You give placebos and we're going to successful placebos also have problems. How do you deal in patient queries as to what are the side effects of this drug, or what are the interactions? How do we deal with that? So is it ethical to offer unproven treatment? What is the WHO consensus on the Ebola outbreak? They have said yes, isn't it? Because we didn't have any other alternatives. But those who are really very worried about the dishonesty in doctor-patient relationship and ethical dilemmas, you can use conditioning procedures. You don't have to use verbal suggestions. You can use conditioning procedures, and this can avoid deception if you think it's going to be a deception. So it may be unethical to use a placebo. It's also unethical not to use something that heals, isn't it? Just because we don't know it. We have the science, but are we making any progress? I'm sure you, Anna, and all the others are going to make great progress. Right now, mechanisms supporting this are only speculative. When we actually know the mechanisms, when we actually prove these mechanisms, then we can come to a consensus. Will placebos be powerful enough to reduce drug use one day? Only time will tell. Till then the dances go on. Thank you.